The Halal Chapter Podcast.
Hello and welcome to another episode of the Halal Chapter Podcast. You're listening to me, Hazira Rauda and Nurul. We're so happy to have a doctor with us today because although she has extracted some time out of a busy schedule, she is very cool, I think, because I found her on TikTok.
Oh, wow.
Yeah, I found her on TikTok. I was like, oh wow.
A doctor on TikTok.
Nice. Exactly. And the most surprising thing is that she's a Singaporean doctor. I don't know why. But when I see doctors on TikTok, it's usually
Americans
in the US, like Dr. Michael something, the guy. But it's so cool to find Singaporean doctors on TikTok and they're actually sharing medical content. So today we have Dr. Suraya, who is an orthopedic surgeon. So in definition, an orthopedic surgeon is someone who is working on the branch of medicine dealing with the correction of deformities of bones and muscles. From the phone.
Okay. From the phone.
Not memorized.
That's right.
Okay. So
Hi.
without further, yes, please introduce yourself.
Thanks very much for inviting me onto your podcast. I'm very honored and very excited to be here. So my name is Suraya. I'm 38 years old. I work in Singapore. I'm an orthopedic surgeon. And as Hazira correctly pointed out, orthopedic surgery is the branch of medicine which is to do with fixing of bones and correcting of bone deformities. So the word ortho and peds actually mean bone and children. And in the ancient times, the branch of orthopedics actually started from correcting bone deformities in children. So if you look on the Royal College of Orthopedic Surgeons, the emblem is of a plant which is tied to a metal rod. And that signifies the history where orthopedic surgery started from people actually tying deformed bones of children to stakes or other things to correct their deformities. So, of course, we don't just operate on children now, but we also do the whole spectrum from infants all the way to elderly. And we do more than just correction of deformity. We fix fractures, we replace joints, we take out bone cancers. We do pretty much anything that you can think of with regard to bones.
Interesting. And before we started recording, we actually say, okay, Dr. Suraya, can you just move to the middle part of the screen so that we can get a better view of yourself? And she was like, no, I have something to show you. Tell us more about what's on your right, left.
Proud. I'm very proud. That's right. On my left, I'm very proud of my knee models here.
Okay.
So I'm just going to bring them a bit closer to the camera.
All right.
So this was given to me by one of the knee replacement companies. And basically it's got a model of like a good knee and then going on to a diseased knee, which are these two over here. And finally the knee with an implant here, which is a knee replacement. So I'm going to bring it a bit closer. You can see it's very nice and shiny.
Wow.
But this is one of the most common surgeries that we do in orthopedics, where we replace the worn out knee. It's called the knee replacement. And, it's something that we do every week, a few times a week. It's really the bread and butter of orthopedic surgery.
Oh, wow.
Yeah, very enjoyable surgery for the surgeon.
It looks really daunting to have that metal piece.
You think so?
Yeah, what actually is it
Yeah,
made
I know.
of?
I mean, patients always think, it's... most of the new implants are made of cobalt chrome. So it's very durable. It doesn't scratch. It definitely doesn't rust. And it's not that heavy. So most patients don't feel the weight of this implant in their knee when they're walking. And it really does allow the knee to glide smoothly and move so that the patient has no pain when they walk. It's really literally life-changing because sometimes you see patients come in with their legs all bent and really walking, almost waddling. And after the surgery, their legs are straight and they can walk. It's really a life-changing surgery.
That is very true. Actually,
so that's what we do in orthopedic.
Actually, my grandfather had a knee replacement, and I've always find it really, really admiring because before he entered the hospital for a knee replacement, he was on not stilts. What's it called? Tongkat.
Crutches.
No. The one
Walking cane.
Walking cane.
Walking stick.
Walking stick, sorry. He was on walking stick. So he would go and change it all the time. And then until he got a knee replacement, guess what? He's going Geylang every day from Bedok.
Oh, that's amazing.
Up and down the bus. So it's crazy how much energy he still has at the age of 80
How
something.
does it feel for him? Does it feel like he's been granted a new leg, a knee?
I think it's not no pain. It's more on the pain is more focused on the energy part, like the stamina, instead of the legs. But I would think he cannot feel that much pain as of now.
Right. Okay.
But if he sits down, you can see that there's a bulge on the knee.
Oh, okay.
Where the knee replacement is.
Okay.
Yeah.
I see.
But I think it's really interesting how like she says, go ahead.
Well, I would say in response to does he feel any more pain? Actually, the main reason why we do a knee replacement is for pain relief, because these patients are in so much pain that they cannot walk. So once we do the surgery, all the diseased bone is taken out and replaced with this brand new parts, right? And basically the knee has no more pain for most patients. So it's really an amazing surgery. In fact, my mom has, and I hope she doesn't mind me sharing, but she herself has had both her knees replaced. And I can tell you firsthand that she's gone from, walking very slowly and always in pain to walking up and down the stairs without any problem. So it's a good surgery to do.
What actually is the cause of, the knees to get diseased?
There are multiple causes. The most common cause is just wear and tear. So it's part of getting older, unfortunately. And it's just like a car tire. The more you use it, the more it gets worn out, and it just doesn't regenerate itself. Unfortunately, our technology isn't so advanced yet that we can enable the knees to regenerate themselves. So we just have to replace what's worn out.
Right. So the bulk of your patients are more the elderly?
Oh, yes, definitely. So knee replacements are generally not done for patients who are under 60 years old. Of course, we do have some exceptional cases where maybe they've had an accident in the past, or they have some other injuries which lead them to have earlier wear and tear. But most patients are 60 and above.
Right. Okay.
Interesting. Okay, let's get back to where I found you, which is on TikTok. So it's really surprising to see a Singaporean doctor on TikTok. I rasa macam like in the States, you see a lot of people showing that they are from medical school, but we don't see that a lot in Singapore, whereby people don't film themselves going to medical school. To see a Singaporean doctor doing TikTok is
refreshing.
Yes. I was like, wow, she really poked that antigen test into her nose. COVID test. Yeah. So share more about that.
Well, I think my journey onto TikTok was a very experimental one. I'm not big on social media. In fact, it's only been recently after I qualified as a specialist that I started really being active on Instagram and on TikTok. And it was actually one of my friends who said that, if you want to build up your Instagram followers, then it starts from TikTok, because that's where all the young people are. And I was like, okay, an auntie like me. And I'm like, okay, I'll go join TikTok then. And it's really quite addictive because the videos are short and catchy, and, they're playing the latest music. So, all these trends are really big. I can't say that I'm a dancing TikTok doctor, which I'm glad. But I do like to share some of the things that I do on a day-to-day basis, because I think that a lot of people don't know what a doctor does. Yeah. And I think that it's maybe interesting to get a glimpse into my daily life. It actually started out with COVID-related videos. So I was talking about masks, and I was talking about the swab test, because a lot of my family and my friends were very worried about having to do a swab test. And because I'm a frontline worker, I have to do my swab test every 2 weeks. So I guess you get used to it, and it's really not that bad. I mean, it's a bit uncomfortable, but it's over in a couple of seconds, and it's not that bad.
That's true.
So from there, whenever I have time, I just take a few videos. I just, even in the OT, sometimes my one of the girls who are assisting me, sometimes they just snap a video for me, and then I just upload it. It's quite easy and fun and painless, really.
Oh my god, I can't believe she said she took a video in an OT.
Yeah.
I don't know why. I just feel like
I feel like in Singapore, like, it'd be difficult to do that. So they're okay with it, like
filming in an OT,
filming in a hospital.
Well, okay, so there are some unwritten rules. So, for example, you mustn't ever showcase a patient without their consent.
All right, for sure.
I try to avoid putting anything gory online, because I think some people might be disturbed by that. Definitely nothing which can identify the patient, like any birthmarks or any tattoos or anything. So I try to avoid putting any patient parts on my videos. But it's mainly about me, I guess, and some of the instruments that we use. I mean, a lot of some of the viewers have said that, oh, it looks really disturbing. It looks like a torture device. I'm like, yeah, I guess it does. And I just take it for granted because I use it all the time, right? But I find it really fun. I find my job extremely enjoyable. I find it fun to be able to play with all these different tools. So, why not share online and let people see what it's like?
Yeah. I actually saw that video. I saw the video where you were in the OT and then you had like this bone saw?
Is it?
A tool, and like you were in scrubs and like, not scrubs, like what's the PPE, is it?
Scrubs.
My surgical gown.
Surgical gown, and like there was blood on it. And she's just like smiling with that tool. I'm just like, wow.
Well, let me tell you one thing. If you're disturbed by blood, then you cannot be a surgeon. Definitely you can't be a surgeon. So, I mean, we get used to it. I guess initially when I was a medical student and you first start going into OT and you see blood, you smell blood, it feels a bit strange initially. But now, we're so used to it. We can talk about what we're going to have lunch while we're operating. So...
Yes, and I also found out from TikTok that they actually play music in the OT.
Oh, nice.
Is it true in Singapore?
Oh,
yes,
Grey's Anatomy was right.
Have a little competition to see. We always have a competition to see who has the coolest playlist.
Oh, is it? Oh my god, that's cool. Okay, so since young, I think as children, when they say they want to be a doctor, they don't actually think about being a surgeon, I think. So when they say, I want to be a doctor, it's more on GP and like, oh, I want to help my parents, or etc. But since young, is it a dream to be an orthopedic surgeon, to be exact, or a surgeon in any fact?
I think I always knew that I wanted to be a doctor. Of course, I'm from an Asian family, so I think the idea was incepted into me by my parents, which I don't blame them for. I think it's a good profession. It's a very stable job. There's nothing bad about it. So I always grew up thinking, that's my aim. I'm going to be a doctor. I didn't really know I wanted to be a surgeon until quite a bit later when I was in medical school, when I found that, it feels so natural to be in an operating theatre. I feel like I like dealing with surgical problems. I'm good with my hands. So it was a natural progression towards being a surgeon. But even after I became a doctor, after I graduated, I didn't know exactly what type of surgery I wanted to go into. So initially I was interested in doing breast surgery and like reconstructive breast surgery after removing cancers. But actually it turns out that I didn't enjoy that work. And I happened to do a posting in orthopedic surgery when I was a very junior doctor, and I enjoyed it thoroughly and I never looked back after that. After that one posting in orthopedics, it was just orthopedics all the way. So you could say I fell in love with it.
What made you fall in love with it?
It's very mechanical. So everything is very logical. If you've got a broken bone, there's a certain way to fix it. There's a lot of physics involved in what kind of implants you use, how many screws you use, how long the plates are going to be, what kind of cuts you need to make on the bone. Everything is very precise. And I like that. And I like that you always have a plan before you're going in for surgery. You know what implants you're going to use. Everything is very methodical.
Right.
And the outcomes are very predictable if you do things right. So I like that everything has a cause and effect that is very precise. That's what I love about orthopedic surgery. On top, that's a technical aspect, but on top of that, the patients do so well. When, for example, a young guy comes in with a badly smashed up bone, you fix it and you see him walk within a few months, that's so gratifying. Of course, every aspect of medicine has that gratification when you help a patient and you see them improve. That feeling is something that you can't put a price tag on, even if you get paid a lot also, that satisfaction of helping somebody, it's priceless. So I think in every aspect of medicine, you get that satisfaction. I guess it's really what floats your boat and what lights your fire. And for me, it's orthopedic surgery.
Aww, that's nice.
It's really cool.
I think it's true. Like, especially, I think seeing older people getting renewed, or getting like a fresh start to like their bones, etc. I definitely think it would be rewarding as a doctor.
Yeah.
So I find it really satisfying or very rewarding when I see a lovely little old lady who comes in, some nyonya or some makcik, and they have like these legs which are really kaki bengka, like really curved and deformed because of the osteoarthritis or the wear and tear. And after the surgery, maybe they do one leg at a time, right? And the leg becomes one leg is straight and one leg is curved. And they're like, oh, doctor, when can I do my next one? And you feel so good because the patient's asking for surgery and the patient's like, oh, can you help me again? You know, it's such a wonderful feeling. And it's so wonderful to see a patient who was on a wheelchair before. When she came to see you, she's able to walk in and out of your clinic room. That's really fantastic.
I know you mentioned that a lot of your patients are 60 and above because of wear and tear, because of natural wear and tear in the knees.
Yeah.
But is there something that we who are not there yet can do to take care of our knees better so that we know when you reach that age, it's not
definitely.
as serious?
Yeah, definitely. There's loads that you can do actually. So especially as young women, I think we fall into a demographic where maybe we don't exercise as much or, not to be racist or anything, but we find that a lot of Malay women tend to be overweight. So being overweight definitely puts a lot of strain on our joints. So it increases the rate of wear and tear. So for example, if your car is very heavy, your tires are going to wear out faster. So it's the same for your joints. And there are other things as well. So for example, if you've had an accident in the past or an ACL injury, all these things can predispose you to having increased wear and tear. The nature of your job, for example, if you're an athlete or if you're someone who does a lot of being on your feet the whole day, up and down stairs, all these things can affect how fast your joint wears out. So basically, it's the more you use it and the more weight that goes through it, the faster it will wear out. I mean, there's a fine balance. It doesn't mean that if you don't use your knees at all or if you don't walk around, your knees are going to be fine forever. I mean, your knees are just like the bone and the joint, right? But surrounding all of that is all the muscles, and you need to have a good, robust set of muscles to also support your knees or your other joints. So it's a balance between not overdoing it and like abusing your joints, and also doing enough so that you maintain good muscles, like good muscle tone and good strength, and also not being overweight. It's a variety of factors.
We'll start taking care of our health, guys. Of our bones.
I already have weak knees from all my bouldering.
Okay.
It's surprisingly more common than we think. I mean,
for sure.
I'm coming up to 40 soon, and sometimes I do feel some stiff knees or my knees ache after a whole day of standing, and then it's a reminder to myself, right? Oh, I need to strengthen up my muscles more so that I can do my job. I don't feel tired all the time. Don't feel so old. And I'm sure a lot of people feel the same way.
Yeah, it's a good reminder.
The other day I was doing a back squat in the gym. I was like, hey, why is my knees painful? I've never felt this before. Just like, I'm 22. I'm not even like 25.
22? Wow, it's so young.
Yeah, so I'm like, okay, I have some things to work on.
Yeah. You're at the gym and doing a back squat, so that's somewhere.
Okay.
Starting somewhere.
But it's very easy. It's one of the easiest muscles to train up, like your quads, right? I mean, a lot of people focus just on their quads. It's so easy to train up. So there's definitely a lot that you can do to strengthen up your knees before you need any sort of surgery at all. In fact, surgery is always our last option. We always try medication, physiotherapy, injections, and then if really all of that doesn't work, then we do surgery. I mean, I'm a surgeon. I love to operate, but I don't be like, hey, everybody do surgery.
Just for your own satisfaction.
You're fast, right? Okay, that's just suggestion. Okay, wait.
Yeah, it's always the last option.
Now I have a question. Okay, let's say if someone is working out on quads and then they feel strain in their knees. How do they know whether they are straining their knees? Is it a word? Well, how do they know if they are overworking their knees or something else? Or like they should push themselves further or that it's okay?
Right. That's a really good question because, my patients say that all the time. I go for the physio and then my knee feels worse because I'm always swollen and painful after that. So I always say you need to start slow and you need to build up. If you've never done a squat in your life and you're some grossly overweight middle-aged lady who needs to exercise but has never done it before, don't go and do 50 squats in one day. I mean, your knee is obviously going to hurt because your muscles have never done that before. So I always say start slow. So for people who have never done any exercise before, just do exercises while you're sitting in the chair. So just do straight leg lifts while you're sitting down. And if you can do 10 of those, the next day, build up to 15 to 20. It's a matter of building up slowly. You're not going to get fit by doing 100 squats when you've never done squats before. But it's a matter of building up their strength slowly. So most of the time, if they build up slowly, then they don't feel the pain. But if they overexert themselves and they haven't done that thing before, then they're definitely going to feel pain the next few days. And pain is usually a way of your body telling you that you've done too much. So listen to your body. And if your knees are swollen, painful, then take a rest. Because obviously, if you do too much exercise, you can also end up hurting your knees and damaging your knees. So it's always good to listen to your body and take it slow when you need to.
Right.
Okay, there's something to note.
Yeah.
Okay, so what is it like a day in the life of an orthopedic surgeon?
Long.
It starts very early. It's not so bad now, I have to say, because I'm kind of a consultant already, and usually the junior doctors go earlier into work. But when I was a trainee and I was like a registrar or a medical officer, I used to start my day at 6:30 in the morning, like 6:30 in the morning in the hospital, which means that I would get up at 5 or even earlier than that to get ready and get my stuff ready before I go to the hospital. So by 6:30, I would be looking at all my patients' results, looking at all their x-rays, just making sure that they were stable overnight, no fevers, no any events that were worrying. Because overnight is when bad stuff happens in the hospital, right? Patients have like chest pain, heart attacks and stuff. So we always need to make sure, when I was a trainee and, I had another boss, I would always need to make sure that all my patients were okay overnight so that I can tell them during rounds that, okay, this is what happened to the patient. So when you're a trainee, you're expected to know every single thing on your fingertips. Like, what's their blood count? What was their blood pressure? What's their heart rate? What's their urine output? Really minute stuff. And it might seem mindless, but it's actually all important. All of it contributes to the patient care. So now that I'm a specialist and I have my own registrars and my own medical officers, I can come a bit later. But I still expect my registrars and my medical officers to know all this information, because it's a form of training. If you don't build that discipline to check on everything, then when you're a consultant next time, then you're also not going to check and you're not going to bother about all these things. So it really is discipline. Frequently in my hospital, we start our morning meetings at 7 o'clock. So previously would have to be physically in the meeting room at 7. But because of COVID, everything's gone online now. So sometimes I start the meeting at home at 7, but usually by 8, I'm definitely in the hospital. And some days it still starts early. So some days, for example, when I'm on call, I don't need to stay in the hospital anymore, but I do need to come early to see all the new admissions overnight. So whatever fractures have come in, any accidents that have come in, I need to see them early in the morning before I go to the operating theatre or before I start running my clinic. And that sometimes I come as early as 6, sometimes 6:30, depends on how many new admissions there are overnight.
So they let you know the night before? Do they let you know?
The team on call usually keeps me updated. So they will let me know there's a lot of admissions. So it's more than 10 before midnight. Then I know that I need to come in early just so that I can see everybody and assess them properly before I get on with the rest of my day. So, priority is always for the patients. We must always make sure that everybody's adequately taken care of. There's no lapses in care. Our primary responsibility is to the patient.
Right.
So that's just the morning. And so it depends on what I do. On different days, I do different things. So I have a clinic 3 days of the week, and I operate 2 days, the other 2 days in the week. So when I'm in clinic, my clinic starts at 9, and then it usually runs until 5 o'clock. And I see anywhere between 30 to 50 patients in the whole day. So it can be quite busy. Sometimes it's very busy. We don't even have time for lunch. So we rely on coffee to keep us going. If we're operating, it can also be busy. Sometimes we do one big long case, which can last, up to 8, 9, sometimes overnight. And sometimes we do smaller cases, and we can do 5 or 6 smaller cases. And in those cases, we usually aim to end by 6 or 7 o'clock. So it's really varied. No one day is the same, which keeps it exciting and interesting. Sometimes we have these big overnight cases that are 30 hours, 35 hours, and they're really tiring and very demanding, but they're exciting as well. And, it has to be done. So we all rally together and we do it.
What's the longest surgery that you've been in?
36 hours.
And that's just you are the only surgeon for 36 hours.
No.
Okay.
So that's not safe. It's not safe for someone to be up for 36 hours. So in fact, for that particular surgery, there were actually 4 different teams of doctors.
Right.
So there were colorectal surgeons, vascular surgeons, plastic surgeons, and orthopedic surgeons. So this was a big tumor in the spine. And because I'm the orthopedic surgeon and the bone was involved, we are also involved in the surgery. So we do take turns, but we have to be in the hospital and we have to be awake throughout the whole duration of the surgery. It can be very tiring. But even within those 4 teams, I mean, the colorectal surgeons will have 3 of them operating, plastic surgeons will have another 3, orthopedic surgeons will have another 3 or 4, so there's always a multiple. Yeah, it's not safe to have one person.
Yeah, for sure. Yeah.
And it's difficult. We always operate in a team. It's all about teamwork.
It's a lot of work.
Yeah, like
even when she says like before she became a specialist, she had to know like the blood count, the urine output. I'm like, what?
I have a question. Like, I don't watch Grey's Anatomy like they do, so I'm not really. And I know the journey to becoming a doctor is really a long and arduous journey, and it takes years, right?
Yeah.
And I know, like you first join, you become like a resident or something, and then you become a fellow.
Yep.
And like, what exactly is like
hierarchy?
The trajectory or the hierarchy?
Okay, that's also a very good question. So when you're a medical student, basically you're at the bottom of the feeding chain lah. So you have to do everything that nobody wants to do, like get coffee and stuff.
Right.
But basically you are there to learn. So as a medical student, you're not really supposed to be doing anything significant to the patient. So you're there to observe. You can do something under supervision.
Yep.
But because you're not a fully trained doctor, we will never expect you to do anything which could possibly do any harm to the patient. So for anyone watching this podcast, not to worry, all medical students are always supervised and they're there to learn. But there's always a doctor there and someone who's qualified to be able to do whatever they need for them. So there's, depending on where you go to medical school, there's 5 or 6 years of studying before you graduate as a doctor. But when you graduate as a doctor, it's like being born. You really do not know anything.
Yeah, the transition.
And when you go into the hospital, it's in like going into the big bad world. I remember because I trained in the UK, I trained in Imperial College London. And when I came back to Singapore, I'd never worked in Singapore before. I'd never done a medical attachment here before. So I didn't know anybody. I didn't know how the computer systems work. I didn't have like any friends I could call for help. And it really felt like being thrown into the deep end. It was a very tough year. And I frequently came early as 5 a.m. and left at 10 p.m. for at least the first 6 months.
Oh.
I remember like my then fiance would be waiting downstairs in the car park for me. Sometimes I tell him like, oh, okay, I'm done. You can come and pick me up. And then something else, oh, doctor, you need to do this. And it will be like another hour or 2. You just wait for me. So it was a tough year. And I think a lot of the house officers, so they're called house officers, the first year doctors. A lot of the house officers, it's a steep learning curve. It's a steep learning curve. And that shock of knowing that, oh, I'm actually responsible for somebody now, somebody's healthcare, somebody's well-being. I think that can be quite stressful. So I think a lot of the interns or the house officers, they can be under quite a lot of stress. So that's the first year. You're an intern or a house officer. So a lot of the house officers in Singapore are younger than the interns that you see in the medical dramas, because in America, their medical education is slightly different. So for Singaporeans or a lot of other Asian countries and also in the UK, after A-levels, you can go straight into medical school, but not for Americans. So Americans will do like a basic degree first, and then they will go into medical school. So they're just a tiny bit older, maybe 3 or 4 years older than our fresh graduates when they become doctors. But that being said, the Singapore graduates are very good. NUS and the other medical schools here train them very well. So a lot of them, when they reach the hospital level, they're good doctors. They're competent. So after you finish your 1 year of internship or housemanship, then you become a medical officer. There are 2 types of medical officers. They can be like undifferentiated types, which means that they just rotate through different postings and they're not specialist trainees. Or you can have medical officers who are specialist trainees, which means that they are committed to one specialty and they will train preferentially in that specialty so that they can work towards becoming a specialist in that area. And then after medical officer, the next tier up is called registrar. And that's kind of in between being a consultant and a junior doctor. Yeah. So by the time you're a registrar, you're expected to know quite a lot of specialist stuff. You know, you're usually the most senior guy in the team on call at night in the hospital. So all the acute emergencies, you will have to consult for them. And then after registrar years, which is usually 3 years, then you take some exams and then you become a specialist, which is where I'm at now.
Wow.
It's a long journey.
It's long. It's really long. It's really long. So I graduated in 2008. And I only qualified as a specialist in 2019.
Whoa, that's 11 years.
Yeah. I mean, I took a year off to have kids. I have 4 kids, so I took a year off to have some of the kids.
All in 1 year.
So I had one before I went into specialist training. I had 2 kids while I was in specialist training, and I had my last baby. She's 1 now. I had her just after I qualified as a specialist. So I had a bit of a delay. But if you're really fast, you know, and you get into training straight away or get into your specialist training straight away, then you could possibly be a specialist within 6 years of graduating from medical school, which is very fast. Yeah, so you could be a specialist at the age of like 33 for some specialists. Yeah.
It's impressive.
Yeah.
But it's a long road. So I mean, if you imagine 5 years of medical school plus for me, it was another 11 years, you know, I've very long now.
You must be really determined and like, you know, being very passionate about medicine to begin with, to even be in. I just can't imagine how long it would take and whether or not I would have the stamina to even go through 11 years just to become a specialist. And that's just the tip of the iceberg, you know, because you still want to continue improving. And wow, I'm like living vicariously through you, man.
It's never too late for anyone. You know, there's loads of mature students, people who decide that they want to do medicine late.
So you start.
It's a very fulfilling job. But you're right. You know, I felt that I was taking exams for so long, and it was only like maybe a couple of years ago that I took my last exam. It was such a wonderful feeling. But can you imagine at like 30 plus, you're still studying, exams? At some points, it's also quite depressing. It's stressful. You know, you can't spend time with your kids. So it's a huge commitment. It's a huge commitment.
And how do you balance like mom life and
work life and own time?
That's true. Own time.
I think it's impossible to get the best of everything. It's possible to have everything, like have a little bit of everything, but I'm not as hands-on as some of my friends are. I definitely don't spend that much time with my husband or my parents or even my own kids as much as I would like to. It's just not possible. You know, even on the weekends, I go into work, you know, when I have patients who are not well, I'll go into work every day, Saturdays, Sundays. I'll see them in the morning, make sure they're okay. So like to have like a staycation, it's quite difficult. You know, I feel like it's very difficult to switch off because I worry about my patients. You know, are they okay? I'm always texting my team, you know, can you tell me what's happened to them today? So it's difficult when there's a human life involved, you know, you can't just switch off.
Yeah, definitely.
Yeah, so it's difficult to balance, definitely. And I have a huge tribe who supports me, like my mom, my mom's sister who lives with her. They take care of my baby all the time. They ferry my son to and from school. I have a helper. I have my husband who's very hands-on. So, you know, I have bosses who are very understanding if I need to leave. So it really takes a whole tribe of people around you to support you. And there's no way that I would ever say that I can do this by myself because that's just not true.
Yeah.
I wouldn't be able to do it on my own.
Quick question. So I've seen like a couple of new moms who have some kind of separation anxiety. Is that what they call? When like they baru give birth and then they have to go for work for the first time. How do you manage that?
Isn't that normal? I mean, who wants to leave their baby, right? It's totally understandable. And I tried to mitigate that by taking some no-pay leave. I mean, I know that not everybody has that luxury, but on top of the 4 months that is given by the government, I also took almost 2 months, you know, plus the annual leave and all that. I tried to make it 6 months with the baby so that I could breastfeed the baby for 6 months before going back to work. And it's hard because you got to take no pay leave, you get a bit of a pay cut, and it does also affect your career progression. So when I got pregnant with my second kid, when I was in surgical training, my program director actually said, if you miss the 6 months because you're taking maternity leave, then you have to drop back a year. I was like, how is that fair? I'm only missing 6 months, don't make me drop back a whole year, right? So since he said that, I said, okay, then I'll plan to have another kid when I'm in residency so that I can miss 2 6-month blocks and then I'll just drop back a year. At least make the most of it. Yeah, that's right, betul. Yeah, so that's what I did lah. So I had 2 kids while I was in residency. So I dropped back 1 year, but I kind of felt that I maximized that time.
Yeah. I mean, some people might find it like, oh, sayang dia, 1 year, and like you are 1 year late with your friends.
I am. Yeah. So some of my colleagues who started training with me, they have become consultants. I mean, I'm due to be a consultant at the end of the year, but at the end of the day, it's just 1 year.
Yeah.
And I'll never get 6 months back with my kid,
For sure.
So it's okay.
Yeah.
I mean, it's totally normal to have separation anxiety, but I just kind of got on with it and I just tawakkal lah, just, okay, my mom's going to take care of my kid. I couldn't think of anyone better to help me with the babies. So I just put them and went. Alhamdulillah, they're okay.
Yes. Okay, so...
Well, I think another thing that I want to say is you can't be too perfectionist lah. You can't be like, oh, I want to breastfeed my child until the baby's 2 years old. You can't be like, oh, we just want to do organic food. Only you just gotta relax a bit, because if you're entrusting somebody else to take care of your child, then that person's gonna have their own styles which may not agree with yours. And I think if you get worked up about every single thing that's not done your way, then it's going to be very stressful. So I mean, work stress is already enough. So just relax.
Be happy. Okay, so I've talked to you about this, and when I first see that you're an orthopedic surgeon, I instantly think about Dr. Kelly Torres. So if you don't know who is Dr. Kelly Torres, she's basically a fictional character from Grey's Anatomy, and she specializes in orthopedics. So one of the things that the doctors at Grey's Anatomy say about her when she first come in is that, oh, that's just like bone people. She's basically not a doctor. She's just like someone who moves bones. So I'm not...
What?
I don't know. But she was seen as a character who is less special, I would say. Like, nothing special about her. That kind of outlook on her. But I think as her character grows, it really shows how much energy and physical strength she put in, like in her surgeries. So I think there was this one scene where someone broke his ribs. Someone misaligned his hips, and she put in the force and like get on top of the table and like push it in. And then he was
I've done it.
So I was gonna ask you, is that normal or is that just dramatized?
I mean, orthopedics is traditionally an extremely male-dominated field. So globally, there's less than 5% of female attendings or female consultants. In Singapore, it's about the same. Also, traditionally very male-dominated. It's changing a bit more. So there are a few more ladies. In fact, I'm one of 4 female consultants in my department, which is only 10%. But nonetheless, there are still 4 of us, So I think there are definitely more women who are wanting to go into orthopedics. Yes, it is a very physically demanding specialty because, there's a lot of banging with mallets and all that. So you do need to have some physical strength. And I have to say, even my hand size has increased since I became a doctor. Wow. So we wear gloves, and I have the gloves of sizes. So my size has gone up from size 6 to 6.5 to 7.
Wow.
So dah besar lah, but it's okay, it's part of the job.
So cool.
And in my home, I'm the one who opens the jars and stuff.
Yes, queen.
So it's this funny little quotes like that. But one of my consultants always said to me, it's not about the strength, it's about the technique. And I find that that's so true. So if you don't have the technique, yes, you can compensate by using brute strength. But if you have the technique, actually, it doesn't require Herculean strength. You can just gently tease it back in. Whatever is dislocated, I've reduced dislocated hips, I've put back dislocated shoulders, I've had to put in metal pins into fractures and pull bones. We do that. It does take some physical strength. So you do need to work out a little bit. You have to have some muscle bulk, but you don't have to be the Rock to do orthopedic surgery.
It's interesting because when you say you need to move in bones, etc., I was just sorry, I lost my train of thoughts. Damn it. I had it. So sorry. I think we'll move on to the next question. Okay,
so I'll come back to that point where you said that people don't think that orthopedics are, as special as the other specialties. And it's very true. Actually, we always considered the meatheads in the hospital, the brute surgeons, who just bang stuff in. I think they're just jealous.
Okay, now I remember. So, being an orthopedic surgeon, ataupun someone who is involved in the bone industry or the bone aspect of the body, I think that sometimes you can feel if a bone is dislocated by just touching the body. Is that true?
Sometimes I can tell if a bone is dislocated by just looking at the patient.
Yeah, how do you do that? Macam in the medical school, how do they teach you dislocated? Because unless you see in a scan, then you can see visually that it's dislocated. But how do they train you to feel on the outside?
Yeah, it's a great question. I mean, when you start learning about stuff, you always start with what's normal. So I know very intimately what's a normal shoulder is supposed to look like. What does a normal hip look like? So when something doesn't look normal and they have a history of a fall, for example, or the leg is in a position that is abnormal, and immediately I can tell. Sometimes I don't even have to do an x-ray. But of course, x-rays are essential and we do them routinely because it's part of our practice. We will want to do an x-ray to see whether the joint is dislocated. But, if you have enough experience, you should be able to tell whether the patient is dislocated or not just by touching, observing, trying to move the patient. Actually, in the olden days when they didn't have x-rays, they came to diagnosis, came to figure out what was going on only by looking at the patient, talking to the patient, and trying to examine the patient. So that's real, the real art of medicine or real art of orthopedic surgery. You need to be able to find out what's wrong with the patient just by talking to him, by looking at him, and by touching him. All the rest is just double confirming. So you must have your diagnosis in your mind first. Doing an MRI or doing an X-ray is not hunting for an answer. You should have the answer. It's just to confirm when you do all these MRIs and X-rays.
On the textbook,
in the 11 years that you have been a doctor or you started as a medical student, is there one kind of memory that stuck out to you as I don't know, when you how you say some people cannot stand blood, so that kind of maybe that triggered you, or there was one time when someone come in with a displaced something and you'd be like, I don't know if I can do that.
I mean, actually, I haven't actually spoken much about this, but my subspecialty interest is actually bone cancers. So I'm a patient. I'm a doctor who deals with bone tumors as well as any tumors in the limbs. So I have patients who are sometimes very young, and sometimes they come with tumors which spread to other places by the time they see us. So it can be very sad. So I had one patient who was very young. He was only 25, if I'm not wrong. And he had what we call an Osteosarcoma of the leg. So it's around the knee region. So Osteosarcoma is a very aggressive bone tumor. And usually at the time of diagnosis, sometimes they would already have spread to the lungs. Oh. So I remember this patient, he was undergoing chemo, and then we did a surgery for him to take away the part of the bone that was affected by the cancer. And then after his wound had healed, he underwent more chemo. And it's just so sad because after all this chemo and surgery and more chemo, at his next scan, there was nodules in his lungs, which is totally bad news because it means that the cancer has spread to somewhere else. And I mean, this patient was from overseas, so he kind of went back and he never came back to see us. So I guess that's what's happened lah. He passed away after that.
It must be really hard.
I mean, it does happen from time to time, and it's very sad. I don't really like to kind of bring it home with me or make it too personal, because then it makes it very difficult to work. Your patient doesn't want someone who's emotional. Your patient wants a doctor who is able to function and think about what's best for him. Sure. But it does affect me. All these young patients who pass away, it can be very sad. I also had a patient who, quite an elderly gentleman, 70 plus. He had this growth on his toe, which turned out to be some form of aggressive skin cancer. And so we spoke to him and said, it's a very bad cancer and we have to amputate your leg. And I think amputation is so common for us. We do amputations all the time. But for the patient, it's like, wow, I've had my leg for 70 years and asking me to amputate it is like asking me to break up with my wife or divorce my wife. It's something that's been with him his whole life. I remember sitting with him. He was in a wheelchair. I was sitting with him and showing him the scans on the computer, and then I just saw one tear. Because this is very tough, like other tattoos, this tough Chinese guy. Yeah, then I just saw this one tear come out. Then he just nodded slowly and said, "Okay lah, 可以啦." Like, okay lah, you can amputate my leg. I was like, wow, senior. Yeah. But, it happens lah.
I think you definitely cannot be excessively emotional as a doctor.
No, I mean, if the patient's crying, they don't want to see you crying as well, right? You have to be sympathetic, but I think they don't need you to be emotional. They need you to be their doctor.
Yeah, and they need that assurance, I think, from the doctor.
That's right. That's right. Yeah, but it can be quite heartbreaking at times.
So, do these situations, like very difficult situations, like let's say a patient who experienced a very massive crash, or all these things that we see in medical dramas, do they actually happen every day?
Yes. Not every day, but they do happen. So sometimes when you're the registrar on call and you're in the hospital, you're like, please don't be accidents today. Because it can be very daunting. You can imagine that you're not a specialist yet. You're training to be a specialist, and then you get this call saying, oh, we've got a polytrauma. Polytrauma means a huge accident where more than one system is involved. So for example, they got lung injury and they've got abdominal injury, they've got bone injury. So basically it's bad news. It's going to be a lot of work for you that night, and patient might be very sick. So yes, we do get them. And sometimes it can be from things like industrial accidents where patients fall from heights, self-inflicted accidents. People try to hurt themselves. It can be from road traffic accidents, motorcycle accidents, very, very common. So we do see a lot. So sometimes we see things like open fractures where the patient comes in with multiple broken bones, some of which the bones are actually sticking out of the skin. So all these are always bad news, because you know that the patient is going to be with you for a very long time. And that's not the problem. The problem is that even if they're with you for a long time, sometimes, they end up with an amputation, or they are not able to walk properly after that. So the outcomes are not very good when there are very, very bad accidents. Yeah. So I had patients who stay on the ward for 3 months, 4 months. They have to go for like 10, 12 surgeries because we have to keep on cleaning up the wounds before we can fix the bone. Yeah, it is like what you see on Grey's Anatomy. We do see patients coming in with bones sticking out of the skin, sometimes bleeding from everywhere. It can be quite gory.
Okay, it's good to know that Grey's Anatomy is true.
That's what you want to do.
It's pretty realistic, actually.
This is the whole part of this podcast.
It is pretty realistic. I mean, I don't have a McDreamy or McSteamy, but
your husband. External.
The medical part is legit.
Okay, that's great. Okay, so the controversial thing that I want to ask you is, I don't know if it's controversial or if it's even related, but is chiropractic part of orthopedics, or does it have anything to do with your bones? And is it advised?
It's like a bad word in orthopedics.
Oh my god!
It's not that it's a bad word. Okay, I think that chiropractors have a role. We have a lot of patients with back pain, and some of them feel better after doing the chiropractic treatment. But chiropractic treatment is very wide. So sometimes it's just manual therapy where they massage, they do traction. So traction is when they sort of pull the spine. So I have a little spine here as well. So sometimes when you have a slip disc and the spine has collapsed, sometimes they do traction and they pull the spine up. So that stretches everything out and it makes the patient feel better. So that's all okay. The problem comes when they promise that sometimes they can realign the spine or when they do these cracking treatments, which sometimes can result in some complications. I don't want to, I don't want to knock any chiropractors. I do think that a lot of them do very good work, but I would usually I advise my patients, it's fine to go, just try and avoid the cracking stuff, like the cracking treatments and all that.
That's what you go for.
That's why I
the cracking stuff.
That is what I want.
Sometimes they crack the back and then it has that noise. Yeah, so I don't quite like that because I think sometimes in patients with very soft bones, it can do some harm. So I try not to advise patients to do that.
Used to be
controversial.
But still, that sound is what makes you feel like
it's working.
Shocked,
Yeah.
I don't know, not for Nurul. She's shaking her head.
No, I just can't.
Then you're not meant to be a surgeon.
Personally, I don't like that sound.
Is it? Well, I love it.
No, it just...
Okay, I'm addicted to those. Okay, last question for tonight. 3 things that you would like to remind everyone or anyone listening to this podcast as an orthopedic surgeon.
What can we do to protect our bones?
Yes. Stay away from chiro.
No lah.
No. That's another very good question because I think we neglect our bones until it's too late. So we have a lot of geriatric hip fractures, which means that patients who are old and because their bones are very soft, when they fall, their bones break. And for a lot of patients, it sometimes is the last major thing that happens to them, meaning that they don't recover from it. Sometimes they pass away in hospital. A lot of times they don't recover back to their baseline. They don't walk again after surgery. So I think osteoporosis is a huge issue that we don't deal with or we don't talk about enough. A lot of Asian women don't want to go out in the sun, so we don't get vitamin D from the sun. We don't drink a lot of calcium. We don't take a lot of milk or cheese. So our diet is very deficient in calcium, both of which are important building blocks for our bones. So no vitamin D, no calcium, it's not good news. So please pay attention to your bone health and try and prevent osteoporosis by taking calcium and vitamin D supplements. Okay, so a healthy diet, which includes a lot of green leafy vegetables, a diet rich in calcium with milk, dairy products, yogurt, things like ikan bilis. All these things have, they're a good source of calcium and vitamin D. Make sure that you're eating a good diet. That helps immensely, even sometimes more important than taking supplements because the absorption of calcium and vitamin D from natural foods is much higher than if you take a supplement. The absorption is always a bit lower. So one is diet to prevent osteoporosis. The second is exercise because your skeleton and your bones are just like the frame of your body, but everything else is supported by your muscles. So if you have no muscle tone, if you have no good core muscle strength, then I guarantee you're going to come with back pain, you're going to come with knee pain, you're going to have neck pain. All these muscles at the back here, at the back, your big muscles at the back, your core strength, as well as your big quads, they're really important. So do weight training, some gentle strength training exercises, and I think that will help go a long way towards keeping you healthy. Okay, so this also prevents osteoporosis. So diet, muscle training, and the last thing is prevent obesity. I think obesity is one of the single biggest risk factors for almost any disease in modern medicine. It increases your risk of cancer. It definitely increases your risk of joint degeneration. And it's a huge problem in our community because food is so nice. I understand, right? I also want to eat nasi ambeng every day, but it really isn't good for us. And we need to cut it down. We need to reduce our intake of red meat, sugar. Our teh tarik is so addictive. Other sugary drinks, we really need to cut that down. And it needs to be like a community-wide effort. So everybody needs to consciously not take sugar because we just don't need it. We don't do the amount of work that our ancestors used to do. We are like, look at us, we're sitting down talking, we only move our mouth. So obesity is a real issue as well. Keep your weight down, do your strength training, and make sure your diet is sufficient. I think you'll be okay.
Okay, thank you, doctor.
That's so good. That's a good reminder. I feel like,
Don't call me out.
I need to work on those.
No, I'm not. I think a lot of people are healthy. People are trying. I just think that sometimes life gets in the way of being healthy, and we don't realize it until we are like 60, 70, and by that time it's expensive, and sometimes it's not possible to achieve what we want.
True. And I think also when it comes to like calcium or like vitamin D, we always impose it on our children. Like, oh, children makan this supplement. Tapi we forget about ourselves. Like
personally, I hate milk. I don't drink milk. I think I might be lactose intolerant, so I don't drink milk. But I do try to eat yogurt when I can. I eat quite a lot of cheese, which is probably not healthy either, but I also take a calcium and vitamin D supplement because I've had 4 children, and we know that when you have a lot of children, your body is depleted of calcium stores, especially if you're breastfeeding. So I do try to do that for myself.
Yay! Cool. Thank you.
That is really informative. Thank you so much. I think I've learned. I mean, Hazra's in her 20s, but like I'm not. So this is very good information for me.
One key takeaways.
It's very basic information. It just needs to be reminded to everybody.
Actually, I had no idea that vitamin D was something that we should important for our bone health. Actually,
it's very important. It's actually one of the key steps in absorbing calcium into your body. So if you don't have vitamin D, which you can get from your diet as well as from the sunlight, your body's not going to synthesize calcium. So actually, vitamin D deficiency is one of the main causes of osteoporosis in the Asian community.
So it has to come in tandem. Like you need vitamin D. That's the most important thing. Thus, your calcium will then be absorbed into your body.
Correct.
Cool.
Yeah.
Interesting.
I love it.
I only got to know about vitamin D until recently. The only vitamin C I have is my face. Like I put vitamin C on my face. Okay lah.
That's useful.
Okay, thank you so much, Dr. Suraya, for your time.
It's been a pleasure.
It's been a very tiring day for you, I believe. Thank you so much.
Not too bad. Just the usual day. Thank you very much for inviting me. I'm so honored, and it's been really enjoyable. Thank you so much.
Thank you so much. Okay, for those who are watching this video, don't forget to like, share, and subscribe to this channel. Listen to our past episodes if you haven't, and bye-bye for now. Thank you, guys. Bye.
Bye.
If you're in Singapore, you'll know that food is our #1 priority. Food in Singaporeans are practically inseparable. It's literally the best ingredient for any occasion, any stress you got going on. Food solves everything. Because, for example, if it's your birthday, let's go eat. You got a promotion, you deserve a treat, sayang. You feel like pulling your hair out? Come on, I'll bring you for supper. Yeah, you get what I mean? It's literally perfect for everything. And of course, we want to tell you everything about it. Like places you didn't know were halal, or 12 new halal places you need to try this week, for example. We are determined to make your tummy bigger and bigger and bigger and bigger than last year or any time. So follow us on the blog to get all the insights at www.halaltrip.com, and of course we are also on every social media platform at Halal Trip.
Alright guys, thanks for listening. So we'll see you on the next episode. Don't forget to give us a shout out on anchor.fm/The Halal Travel Podcast. Your voice message could be featured in our next episode.
Yep, and if you have any advertising and collaboration opportunities, contact us at info@halaltrip.com. That's info@halaltrip.com.
Also, don't forget to follow us on our Instagram, Facebook, and Twitter at Halal Trip. We're also now on Telegram and TikTok. Until next time, get inspired, go and inspire others.